All right. Well, good afternoon, everyone. This is Brandon with NMQF. We had a pretty busy week, or interesting week last week, to say the least. So we weren't able to do a lot of questions. We're still up in the air. Well, not questions. A lot of uncertainty was up. But I think by Saturday, we learned that one of our last year's Lifetime Achievement Award winner was elected by in large margins by the people of this U.S., especially coming through with Mia's hometown of Philadelphia as President of the United States. So we're looking forward to 46 and working with 46. And the really good thing about it is that we've worked with him and his team before, whether it be the work at the Biden Cancer Institute, doing the data sets for that, the work on the summit, the work with the head of the COVID task force, former Surgeon General Vivek Murthy. So we have a lot of inroads and connections there, and we know what they ideally what they want to do. We also know what they should do, and what should happen. So we wanted to go ahead and have this conversation this morning, afternoon, depending on where you're watching it from. Like, what does healthcare look like in the Biden administration? We know that there's a lot of stuff it's been released that Chief of Staff Mark Meadows has sent out items to his team asking even though they haven't conceded, saying what are the big ticket things we want to get done in this last 60 some odd days now. And we know that healthcare is always under attack and health equity is doubly under attack. So we want to talk about that and what it looks like. And with that, I'm going to stay on for a bit since I'm a former Biden guy, but I'm going to definitely turn it over to the real experts, me and Dr. Puckrein.
As always, Brandon, thank you for the gracious and stellar introduction to the work that you all are doing at NMQF. I'm always really excited to be on board with you all, as I was saying before the camera came on. And you're right, what a week. What a 2 weeks. I mean, Tuesday was the longest Tuesday that we could have ever had, leading into Wednesday and through the weekend, and I don't know about all of you, but I took to social media, certainly to just watch how people were responding, but then also just to ease a bit of tension or any kind of anxiety related to the election, and so what I'll say to our viewers today, irrespective of where you fall in terms of your political leanings, we have a lot to do, and each of you has so much to offer in your spheres of influence in terms of advancing a really very quality and comprehensive strategy and agenda with respect to the health of the nation in terms of where we're going, and especially with respect to optimizing health and life experiences for all people, right? And so I'm really excited, of course, to have with us the formidable Dr. Garrett Puckrein, who all of you already know. And if you're new to NMQF and you don't yet know, Dr. Puckrein is the president and CEO of the National Minority Quality Forum, and he founded this. This is his baby, right? Founded in 1988, and of course, NMQF focuses on myriad things. Brandon alluded to some of the work that they do and have been doing prior to President-elect Biden prior to his current position when he was vice president, but doing other research and organizational related work amongst historically vulnerable, historically medically underserved populations especially. But then also Dr. Puckrein is through and through a teacher, through and through a researcher. And a lot of that comes out in the work that he leads and the work that he allows his team, or really empowers his team, to explore. And so Dr. Puckrein, as usual, I'm really excited that you're here, sir. Tell us how you're doing.
Doing well, Mia. I'm always excited to be with you. This is really a tremendous moment. There's lots of opportunities sitting in front of us, real work that has to be done. And so looking forward to this afternoon's conversation.
Couldn't get to my mute button fast enough. It's like that game, that groundhog game or whatever that we used to play back in the day, trying to get to this button. Okay, so the other thing is too, Brandon has been so very modest on each of these calls, right? In terms of his work throughout policy, throughout politics, and especially in the health world. So Brandon, why don't you tell us how you're doing? tell us a bit about what you've been doing in the past and recently to lead up to this moment. And then I want to get into a conversation between the both of you.
Yeah, so thanks for that, Mia. I just sort of, I do what Dr. Puckrein says to start, so that's a good way to keep your job, folks. Do what the boss says. But two, I've been working, like historic, I don't know if folks know, but I was full transparency, I was a Biden staffer back in 2012 and 2013, and I worked on domestic policy. And so that's one way that I ended up working here, and then working with Congresswoman Kelly as her chief of staff, and then the executive director of the Health Brain Trust, and that was my real introduction to the National Minority Equality Forum and Dr. Puckrein. And from that, we were able to help craft the HEA bill, which is sort of our kitchen sink and what we think should happen in healthcare policy. And it's one of those huge bills, so a lot of some of it's our pie in the sky ideas, but a lot of that gets picked up in other places. So the HEAA, a lot of the positions that we took in HEA back before 2010 ended up in the ACA bill, the Affordable Care Act. So Offices of Minority Health, more money to minority health, more focus on health equity, that came from that. Then worked in the finance space, but in healthcare finance, so I kind of got to understand a lot what Dr. Puckrein was talking about. We talked about CMS and reimbursements and dish hospitals and all of that stuff that everybody else on the call is probably familiar with well before I was. And then finally came back here to NMQF to work with the team and work again directly with Congresswoman Kelly and Mia at the time. So when Mia was the health fellow. She started off as the health fellow. I think she tried to go to the Senate side, and I think we let her work there for a week, and then we said, hey, could you just come on back and work and take over this portfolio? So
yeah, Brandon, I really appreciate that you gave a bit of history there. And for those of you who are trying to figure out what the acronyms mean,
why
don't you tell us what HEAA or HEA stands for?
Goodness gracious, health, equity, and
yep, Health Equity Accountability Act.
Accountability Act. Goodness gracious, I live in acronyms. I apologize.
Live in acronyms. That is the DC thing. You drink the Kool-Aid, you're going to live in acronyms. So the HEA Act, which Brandon mentioned, is like it is a huge piece of legislation that has been presented in Congress since, I want to say, at least 2010. And as Brandon mentioned, it coincides with the work that the Congressional Black Caucus Health Brain Trust, in coordination with the Congressional Hispanic Caucus, as well as the Asian American and Pacific Islander Caucus in Congress, had put together, and especially out of the House side, or generating out of the House side, and then also working with Senate side members. But it covers everything that is similar to what Brandon mentioned. So a lot of situations a lot of things and that went into the Affordable Care Act, but then a lot of things that we're still trying to work on with respect to advancing maternal health, with respect to advancing racism as a public health threat, gun violence as a public health threat. A lot of these policies and these ideas right now are sitting within this 700 some odd page bill, and we're looking to advance it. And hopefully we'll see some talk with respect to the incoming Biden administration. But to that, I want to talk a little bit about how Dr. Puckrein, how NMQF really has its hand in helping congressional members and their staffers to draft policy. What does that mean? What is the role that NMQF plays there? And then we'll talk more specifics about upcoming administration.
So at the end of the day, it's really always about the data. So the National Minority Equality Forum, we have been collecting health data now for about 20 years. We have a database of over 5 billion patient records. We collect data on about 160 million lives per year. And we take that data, and some of it we publish, and we call them indexes and heat maps that we aggregate up by congressional district and state legislative district, so that we can help members of Congress and state legislators understand the health of their constituents, as well as understand healthcare utilization and costs. members of Congress and are really fiduciary agents for both the Medicare and Medicaid program. Well over a third of the American public is getting their health care through Medicaid and Medicare. And it's important for the members to know how are their constituents faring in those programs, what are their outcomes looking like. And so, you know, for probably over 15 years now, we've been working with members of Congress, sharing that data and helping them to understand the impact of their policies on their constituents, as well as, I should add, not just their policies, but the policies of CMS and payers on their constituents.
And you know, you mentioned Medicare and Medicaid, and Brendan mentioned the ACA. We're talking about big, consequential milestones with respect to health, and usually in response to a crisis at the moment, right? And so in the 1960s, the crisis was civil rights related. Not that we're without that now. We're still dealing with that in probably like a third wave, in the words of David Williams, who's calling for a third Reconstruction in terms of where we're going with respect to our health and of the nation. But talk to us about what has to happen now that we're coming into a whole nother crisis, you know, a syndemic crisis, if you will, with respect to enduring injustices on aligning with racial realities and gendered realities and so on and so forth. What about COVID-19 paired with that enduring context, and where do the policies need to meet? And how does this moment with President-elect Biden and Vice President-elect Kamala Harris, what does that mean for NMQF, and what does that mean for those in the audience in terms of how they need to be thinking about things?
So I think really, you know, the place to begin, as me and all, I'm a historian at heart, and I think understanding the past is really the first step to understanding the future. And so when we look at the American healthcare system, we have to remember that it was born during an era of segregation, in which inequalities were by custom and by law enforced. And so the health outcomes of African Americans and other minority populations were really quite poor in the system, because there really was no attempt to provide them quality care. We have to remember that at the time of ACA, 48% of African Americans had no health insurance. 54% of Hispanics had no health insurance. As late as the 1980s, you know, a physician could deny access to their practice to an African American, or based on race. You know, in the 1960s, there were hospitals where African Americans couldn't go. Now, the outward signs of segregated America are essentially gone, right? But the inequalities in the healthcare system have not disappeared. The language has changed, and really what the healthcare system is doing right now is focusing on managing financial risk, right? So when you think about a program like Medicaid, for example, in which the states have to balance their budget every year, what ends up happening is that for the beneficiaries in the Medicaid program, their health gets turned inside the financial risk of the state. And so you can get poor health outcomes there because the system is not managing patient risk. And that is probably the most important transition that we would advocate for, that we need to move from managing financial risk to managing patient risk. Because here's the point: no patient goes into the healthcare system believing that that system is going to elevate their risk for a hospitalization, elevate their risk for an ER visit, elevate their risk for disability, elevate their risk for mortality. And what we see in some of the policies that emerge is that we have this tiered healthcare system that is in fact doing that. By the numbers, you can show that the healthcare system is producing inequalities because it's managing financial risk. And I think the biggest step forward for us all is to turn the healthcare system around and point it directly at managing patient risk. This will be good not just for minority communities, it'll be good for everyone. Here's what's to remember, and I think about this all the time. So COVID comes around essentially in December of 2019 in China, gets to the US and Europe about March of 2020. We now have a vaccine, right? In less than a year, we are starting to produce a vaccine that can effectively reduce the risk of infection from that disease. Even more importantly, we have, or as important, we have therapeutics that have been developed specifically to address. Lilly just had a EUA, emergency use authorization for a COVID therapy. That's an amazing turnaround that generations could never do before. Absolutely not. And we could do much more of that. We're talking about editing the genome to get rid of sickle cell disease and other forms of diseases. But the challenge, what's limiting our capabilities and our capacity is the financial risk question that the inequalities that it breeds. And so I think the conversation that we want to have and push forward, not just with the Biden administration, with the American public more generally, is that we need to make that transition. Now, you have to say there are going to be others who think that our biology should support our economic system. And so if, you see it already with COVID, right? People are saying, open up the economy. Yeah, some people will die, but we need to maintain the status quo, so let them die, right? And so this is not like it's going to be a cakewalk to make this happen. But the point is, it is the future. It's where we have to go. And we got to get consensus built around the fact that we have to manage patient risk.
Mia, I would just also add that the policy must match the politics. I mean, if you notice, even back in South Carolina, that's when Biden knew that he would take the Democratic nomination. He got the big round of approval from Majority Whip Jim Clyburn in South Carolina.
Shout out to Whip Clyburn.
Yeah, with Clyburn, and he was definitely the rainmaker. He changed everything for him. And from that moment on, he knew the people that supported him, that got him there, were Black and brown people, Black and brown people in major cities. Like I mentioned earlier, Philadelphia, Detroit, Milwaukee, Minneapolis, they came out for him. And we also have to think about the indigenous populations that came out. I think 90% in Arizona for
Yes.
President-elect Biden. And the young people, you got to realize, in Arizona, maybe 10 years ago, those same kids that were the dreamers that were not that were under so much scrutiny back then were now voters. And so if you look at the demographics there, those kids came out at around, I say kids, but those younger voters came out around 70 to 80% in Arizona. That's Phoenix and Tucson. And we always talk about Maricopa County and how it came out so quickly for Biden and held on to that lead. And as of yesterday, we know that he received those 11 electoral votes. So I think the policy will have to match the politics. And so far, he's made good on it. I think that policies that impact and discuss things like health equity and fairness need to be a part of it. And I think that that is in line with what Dr. Puckrein was stating. And I think it's going to have to be reflected in a lot of positions. I know there is some concern, rightfully so, that a lot of the people are names that we've heard before, that we've heard for like the last 10 or 15 years. But I think the way I see the administration, or the new administration doing it, is that we're under all this scrutiny. We haven't even received our funds yet to do the transition. So I'm going to go with some folks that we know that have already sort of been vetted and approved. And as we move forward, we will continue to add and diversify the people that work in this new administration. And then just a quick tag, we are helping the administration get diverse talent, especially in the healthcare space. So I'll have Keiko put the web address in, but you can email us your resume at nmqfresume@nmqf.org, and we will sort of sift through those and send them to the admin, because we know that we have a lot of good talent on our general list, specifically on this call, that can help sort of implement this patient-centered care that Dr. Puckrein speaks about.
Absolutely. And I'll just repeat that backwards, everything that you both have said. for those of you who are interested in coming into the administration or being vetted for, in terms of being useful in the political space here, please, please, please drop your resume in the link that Keiko will, through the link that Keiko will provide via the chat. So it's right there, boom. The both of you are talking about shifts, right? And when we're talking about transitions between administrations, the idea is that there will be a shift, but historically there's not always been a shift in terms of the values that administrations have put forward, right? Not always, right? There's usually a very discernible difference across political parties, but sometimes a lot of people would argue it's a lot of the same, right? Irrespective of the party. Brandon, you're talking about understanding the demographic shifts in terms of where people, I told my father not to call me, but he's calling me right now. That man will not let me go. In terms of the demographic shifts, especially in the West Coast and in the South of the US, there is this broader consciousness that has been brooding for quite some time. But again, according to age, according to political environment, people were not in a position to vote. But now we do see that that age demographic, that regional demographic, also the racial demographic. And Dr. Puckrein, I know you can talk to this point a lot. The nation, and I've heard you use these words, is browning, right? What does that mean for people who are in power, who, to Dr. Puckrein's earlier point, members of Congress especially are beholden to them in terms of being their constituents. Even if that person, that lawmaker, doesn't understand what equity is in health, doesn't understand how health ought to come, health is a part of all policies. What does that, in terms of being the constituent, to what extent, and physicians are constituents, people within healthcare are constituents, to what extent does this body, that constituent body, need to do to really hold members of Congress accountable and thereby holding the administration accountable? And we also can't forget about the courts, but we'll come to that in just a little bit. Yeah.
So, advocacy is a branch of medicine now, right? If you're not advocating, you're not getting. And so it's really important for all of us to remember that we have to continue to advocate, we have to continue to educate for what we want. Mia, you're spot on. America is browning. That population that didn't have healthcare in 2008 got access to healthcare. And now we have to not only hold on to that, but we have to build upon it. Because the future of healthcare, and this is not a minority question, because it's an opportunity for us all. The diseases that used to plague humanity, we can now bring under control. Think about what we did with HIV, what we're about to do with the virus. If you look at the trend lines for cardiovascular disease, if you look at the trend lines for cancer, the ability we have to do medicine at the genomic level, to actually go into the book of life and edit it, right, to cure diseases. We have all of that capacity and more, but we have to unleash it. We cannot leave it bottled up, and nor can we allow it, and it won't even be possible, quite frankly, to let it be just for a few. We cannot build a healthcare system for the 1%. It's not possible, it's not practical, and it'll be important for them to understand the deepness of collaboration in healthcare. So our task right now, the big task right now, is to change the political will, to get away from the conversation about should my neighbor have healthcare, because everybody wants healthcare for themselves. But all of those people who are against ACA, what they're really saying is, I don't want my neighbor to have healthcare, but God, I'd love to have all the healthcare that I can get. We need to brush those folks aside. And what we also need to do is to make sure that every individual who comes into the American healthcare system has access to quality care. It's not predicated on what the size of your bank account, what your skin color is, what your sexual orientation, your religion. None of that stuff matters. What matters is when you come in that door, our job is to lower your risk and make sure you get the best possible healthcare that we can offer.
I got ahead of myself again. I'm so excited about this conversation. So we do have a question about managing that risk that you're talking about. How then does one manage, how does a provider manage patient risk? Should there be some sort of formula that's developed? What would such a formula look like? Should it be pushed from providers? What does it look like on the insurance side? And by the way, insurance companies are playing with now, and I hate to be trite, so not so much playing with, but evaluating social determinants of health, and specifically social determinants of health inequities as a result of where one lives, where one plays, so on and so forth. And they're now, a lot of companies are looking at incorporating that into their risk management formulas. But anyhow, Dr. Puckrein, how do we do that? So
it's a math problem at the end of the day. We literally are calculating risk, and it is a management problem. So let's talk about CMS, because we got to reimagine that organization, right? When President Johnson put that program together, it was a great opportunity because when CMS came into being, two things were happening. One, we weren't taking care of our seniors, and families were getting bankrupt because seniors, when they took ill, family budgets were being blown up. And also we were not taking care of the underserved. But if you look at CMS today and its policies, none of those policies tell you what is the best outcome for these beneficiaries that we are taking care of. How do we reduce the risk for diabetes hospitalizations? How do we improve cardiovascular health in the Medicare and Medicaid program? Those are all numbers that we can put out there that we should be looking at and managing against. No, we have a program like CMMI that all they talk about is financial risk. Let me change payment reform, and somehow that is going to breed us quality care. That's not quality care. Quality care are the number of events that Medicare and Medicaid patients have to deal with in terms of hospitalizations, emergency room visits, disability, mortality. Those are the numbers that are really meaningful in healthcare, and how we need to build our system around those numbers.
Truly appreciate that, Dr. Puckrein, and it looks like a number of people in the chat box do as well. I want to bring it up, Brandon, I want to come back to something that you mentioned earlier about really diversifying, and by diversifying, you mentioned diversifying the administration, right? By diversifying, usually that's code word for bringing in colored folk, for lack of that's what it comes down to, right?
All right.
But really, when we're talking about diversity, especially given what Dr. Puckrein has laid out, it also has to, it cannot just be something that's symbolic. We're talking about people who come with diverse thought, right? And diverse thought really does spring from myriad life experiences. And in that way, I would argue that race matters, right? Or at least the relationship that race has in the US and what that does for one's life experience to their benefit or to their detriment, or to, as a catalyst for resilience, whatever. Age matters, certainly overall just life experience. So talk to us about what you foresee with the COVID-19 task force, some of the players who are on board that might stick out to you or for you, and what gaps still need to be covered. And I'm focusing on that last question in particular because I want for those on the call to think through ways that they, their skill sets might be able to really play out here.
Yeah. Well, when I think about it, like we work a lot with sickle cell here at the National Minority Equality Forum, and you know that Black people from the South in big cities are the ones that are most impacted by it. And we know that it can be a debilitating disease, but the payment methods that you get, that physicians and families get, it's not as high as other diseases. And part of that is because of the same race question that you mentioned. And so historically, Dr. Puckrein always mentions that, that most of the therapies and the money has been made for, middle-class white males, right? But at the same time, just being honest, they weren't the demographic that elected the last president, right? And so you have to think that we're going to think a little bit different, like who that we want to make sure that we protect. We want to protect everybody. We want to make sure that everything's fair. And so I think you're going to get a much more diverse group of people that are working in these spaces. Folks like, we've never, let's be honest, the National Minority Quality Forum never didn't get too many requests from the Trump administration about data. But we've gotten, before he was president, we've gotten a lot of requests about minorities and cancer from the Biden administration. So I know that is something that they are going to think about. And I think it starts from the top down. Even if you look at, the vice presidential pick, right? You can't get much more diverse in many ways than Vice President-elect Harris. But then the people that you've seen on the task force, Dr. Vivek Murthy, who was the Surgeon General, one of his big pushes when he was Surgeon General under President Obama was for looking at health equity. Heck, he was even the first one to publicly mention that gun violence is a public health crisis, which was to our former boss and partner, Congresswoman Kelly, was something that she was always advocating. But he mentioned that at the top of his agenda, he was let go because that was one of the major reasons he was let go by the current administration. So I think you're going to get a lot more diversity of thought and opinion. I think he's going to look for folks that from the obviously NMQF, but NMA, from all the diverse physicians that you work with at AMA, MIA, policymakers. I mean, look at the top of the list right now. Some of the names mentioned for HHS secretary include Mr. Murthy, Karen Bass, the CDC chair. I memean, they're really, the names out there are big and bold and have a focus on minority participation in health. Even the FDA, at the top of the ticket right now, I saw was Johns Hopkins, Josh Sharfstein, who's always been focused on, if you know anything about Dr. Sharfstein, he has been focusing on this at Johns Hopkins for quite some time now. He spoke on at one of our town halls a couple of years ago about how the environment is impacting minority communities much more so in the healthcare. So I think you're getting a lot more of these ideas becoming more vocal and more public and more understood by the general public. And I think that's going to determine who is in the administration and what they're focusing on.
And speaking of public, again, when we're talking about the health of the nation, we have to be very clear, to your point, Brandon, that public health must marry medicine in a way that is valued on both sides, right? We cannot have the conversation that I want to now have, for instance, on vaccines without talking about where medicine meets public health and really medicine extending itself where people are so that we can move forward and with respect to advancing and addressing this particular crisis, this immediate crisis, but certainly crises to come, because they will come, right? So I want to talk a little bit about the vaccines, right? And we can loop in the conversation about diversity and more specifically representativeness, but I want to talk specifically about the science and some of the things that we collectively as a nation might still have questions on and what's to come, right? Dr. Puckrein, you were talking earlier a little bit about the vaccine, so I'll invite you to open up that conversation.
I want to underscore this because I think it's incredibly important to make sure that everyone understands. The conversation is really about everyone's healthcare. We're trying to redress the problems in minority and underserved communities because we had a healthcare system that supported inequalities, that was built for inequality. I mean, it was quite open about the fact that it was limiting healthcare, quality healthcare, in any case, to at that time, a majority of the American population, and had little concern or a low concern for the minority population. But now, as we move deeper into the 21st century, what we're saying is we want to make sure that every person who comes into the American healthcare system has access to quality care, because we're going to get smart about your risk, right? We understand from the world of precision medicine that we're not all alike, we're different. And that difference is going to require us to have a healthcare system that is agile enough to be able to provide quality care to all of those different genotypes, if you will, those different biologies, those different environments in which we all live. And what the COVID experience is telling us, rightfully so, if we had the COVID issue back in 1998, those trials would not have been diverse. I'm telling you right now that in 1998, the trials would have been in white males, and we would have generalized, and whoever survived, if their head fell off when they took the vaccine, okay. If they got better, okay. If they didn't get better, okay. But this time, we're saying that those trials have to be diverse, because when you bring them out to the American public is now diverse. And we need to make sure that they're safe and efficacious. And what everybody says to those innovative companies, we want to see the numbers. Before we go into our community and tell them to take this vaccine, show us the data, right? We got to see the numbers, because we have a responsibility to our community to make sure that those numbers are accurate. And I think they got the message, and I think they're working at that. But the point is, we need you to do that for diabetes. We need you to do that for cardiovascular disease. We need you to do that for cancer, because America is now truly a melting pot. And we want to make sure that all of our people have access to the care that they need. So COVID has really opened up a window of opportunity. It has shown amazing capacity. The fact that we could actually have a vaccine in the space of time that we've been working with this disease and other therapeutics, is just amazing. I mean, you just got to say that's incredible. And all of that was part of a collaboration, right? It was all of us working together to make that happen. And now we just got to keep building on that opportunity and making sure that we reimagine our healthcare system, turn CMS into something else, right? That doesn't sit around and act like it's HCFA, for God's sake. I mean, HCFA was dead, right? We killed HCFA, and you don't want to let it go. And so we need to really rethink and reimagine our healthcare system so that it is innovating, it is helping us build and maintain high quality, long lives.
Yeah. One thing I just want to add to it, because Gary mentioned diabetes, right? And what we do know, like working at NMQF, that is pretty much the most expensive cost to our healthcare system. But we've never had anything like a diabetes czar or someone that are a huge focus that any administration has just taken on that. And I think that's, speaking of, we're always going to, no matter what, we're always going to talk about cost or worry about cost. And I think we need to start the way we attacked the COVID problem or HIV or hepatitis C. We need to do that with some of the traditional diseases that's really impacted us, like diabetes. And I would love to see an administration take on something that big. Just like we did the Biden cancer, the moonshot, we should do that with diabetes and come up with other therapies that save more people.
Brandon, the thing is, this is not rocket science, what you're talking about, right? Yeah. This again comes back to the fact that health is political, right? And the ways in which innovations to these health issues or interventions are approached and eventually implemented has everything to do, again, with who's in office, who's at the table, who's making decisions, and it also does come down to cost in a lot of ways. So it's not just that we have to, I would argue, reimagine our systems. We have to have the conversation and be comfortable as health policy experts and engaging in the political system, we have to be understanding of the economics with respect to these institutions, right? And what that means. And we have to be very open with sharing information about, okay, well, I don't know much about CMS. I don't know much about CMMI and how all of that works with respect to how care is delivered. What does that mean for value-based medicine in terms of shifts from fee-for-service? What does that mean overall? A lot of people don't understand it. And as especially as people who are traditional clinicians, they're not taught on the med school level, dental school level, so on and so forth, to really value and understand the way that policy really pushes care in terms of healthcare, right? And in this case, I want to actually allude a little bit to your shirt that you have on today, Brandon, right? Because what we're also seeing, and I love these social media memes about people saying that, in the past, people have argued that HBCUs can't get you anywhere. You can't really find good talent, which is ridiculous. As a graduate of 2 HBCUs, Cheney University, first historically Black university in the nation, as well as Meharry Medical College, as I was going to Vanderbilt University. Like, I will tell you for sure, it is absolutely because, and I went to Oxford for a time in the UK. So I can, and I went to school in Indonesia. I've been to a bunch of schools. It is a result of, right, it is a result, honestly, in terms of the exposure and leadership influence and just being poured into, and really walking away with this understanding that I have to use my gifts so that I can push forward this agenda of, like Dr. Puckrein said, where we all stand in terms of our health is a result of where our neighbor stands, right? If my neighbor's sick, I'm going to get sick. That's literally the concept of the science of social distancing in COVID. Right. So anyway, the reason I also want to bring up Xavier is because not long ago, and this has something to do with the clinical trials, the president of Xavier, president of Dillard, came out, wrote a letter to their students saying, hey, we've got involved in clinical trials. We want to encourage you to, and we're addressing the issues of mistrust, right? We're addressing in terms of the way that students and just overall people might have mistrust, might mistrust clinical trials and the direction and the science, as Dr. Puckrein was talking about earlier, but then also the trustworthiness of those institutions, because those are very different things. And by the way, when we're talking about outcomes with respect to health and clinical trials and representativeness, mistrust itself does not cause poor outcomes. I want to be very clear, because sometimes we get into the conversation of, oh, well, people are sick because they don't trust their doctors. That is not the reason why they're sick. They mistrust because there is a history of things that render that institution to be untrustworthy, right? And therefore, it's related to disengagement with health systems. It might be a fine difference, but it is a difference, right? So I want to talk about when it comes to not just COVID vaccine and but influenza and everything like that. What role do our institutions play in terms of putting out messages to those who are going to contest, and young people will contest? We saw that in Arizona, as you mentioned. So that's a long way of saying, what's the message from HBCUs?
I honestly, I think when I look at most things that come from politics, I look at everything having to be like a campaign. Like who are you trying to influence? Who are you trying to help? And then who are they listening to? The great thing about Xavier and Dillard, respectively, is that Xavier's known for a couple of things. One is producing the most African-American physicians, and not only physicians, but those in the healthcare space, and 2, their big pharmacy program. Dillard, on the same hand, has a great nursing program and produces a ton of nurses. So you have the leaders of these institutions that put out healthcare professionals talking about there needs to be more trust, and they're willing to try it. Dr. Garrett, I don't know who is the president of Xavier University, was a biochemist beforehand. He has a PhD from Columbia in this. So he really has a great understanding of it. And he understands the community and the distrust, and then also the need for us to participate in this. And he did just kudos to Dr. Garrett and all the university officials that were able to somehow make a university calendar happen during this time. Because I know, I'm just putting it out, Gary's daughter, Gary, by the same name, is actually in her first semester of college right now, and the officials there were they had to do the yeoman's work to make sure that the families trusted them to have them there. And that's the type of people that you need promoting the trials. Like Gary said earlier, Dr. Puckrein Gary said earlier, that folks have access to the data. Folks know who they can trust and who they will not trust. They will historically, you'll typically trust your community leader, a family member, a friend. You know, you two probably get a ton of healthcare questions from every member of your family. I get a few legal questions here and there from my family, but they're going to go who they trust first. And that's what you need to build. That's where you started. It's actually not big to small. It's actually small to big. And so
I wholeheartedly agree with you. How then do our health institutions leverage the way that trust, leverage and replicate trust and trustworthiness to remedy the ills of the past, but then also to just infuse a sense of, especially on the local level, if you infuse a sense of this is where you come to stay healthy, not just this is the place you come when you're sick and when you need immediate emergent care, you know.
Yeah, I think there is in healthcare space, there is the best practice, but you have to hit everybody where they are. You know, when people, politicians are always in trouble for going to churches on Sundays right before their election and campaigning and not participating any other time. You need to be there, not the church, the politician, the healthcare provider, the whomever. You need to be on those Wednesday night services where they're, out there educating. You need to go to their schools. You need to be out there in the community. It is a constant campaign. If you're running for a House seat, for example, that election is every 2 years. This election is every day. You need to be out there almost every day. I have something out there every day because people won't trust you immediately. They have to see the good work that you do and how you've helped someone else. And once that's seen, then you will continue to build trust. But like I say, this campaign is damn near every day. So.
Yeah, I would just add to that. And this I say to our industry partners, we have to build capacity in the minority community, and you have to let us use our own voice. Sometimes you want to work with the people who you've worked with historically and you're comfortable with, but you can't do that here. We're woke, right? And we are wide open, and we want to talk about and design our future as part of the American community, and that takes capacity to do that. And look, for instance, what's going on in terms of information in the African American and minorities communities. We've got foreign, international people essentially invading our community with disinformation against the vaccine, against this politician, against this practice. And the challenge that those in the minority community have is that we don't have the capacity to talk to our community, to give them the information that they need in a regular and systematic way. And the stability of the country has to be built around the fact that people are getting good, solid, trustable information around which they can make decisions for their life. And so that comes out of building structures in those communities and the messages being delivered by trusted voices. And so for those who want to help, and we hear a lot of that everybody wants to help. So here's how you can begin to help. You can begin to help by making sure that those trusted voices have the capacity and resources that they need in order to make sure that we have sustainable, healthy communities, irrespective of race and ethnicity and gender and all that.
I really appreciate that last point, especially Dr. Puckrein. There's power in the background, right? We don't always have to be the one who's leading the charge, the face of the cause, right? Being able to, like you said, make inroads with those who already have the platform, that right there leverages the power that we each individually occupy as experts, but then also collectively that, you know, that stance comes through when you're able to really build relationships with those who are empowered. And it's not that you have to like each other. It's not that you know, it's very much that you can work well together. That's why I truly appreciate what I think the Biden administration is going to stand for, which is serious bipartisanship, you know, and working across the aisle. One thing I want to come back to our last conversation. Was it our last one that we had, Brandon, with Dr. Cameron Webb, or was that 3 weeks ago? Was that the last?
Weeks ago.
Yeah, it was a couple weeks ago. Yeah. So the other way to get involved is, again, for those of you who are clinically trained and maybe your school did not really push or value any ideas that you may have had in terms of becoming politically involved. I really do encourage you to take it upon yourself right now to look for those opportunities to understand how policy and medicine must overlap and already do overlap. Are there fellowships that, I mean, for many of you, you're 40 under 40 members with NMQF. Stay in touch with NMQF, because always between Brandon and Dr. Puckrein and the whole team, they're going to put out information that you can then translate into a really very valuable way for those who are going to listen to you, right? But then also there'll be other opportunities that are coming down the pipe. I know AMA is going to come out with some things, and we'll be making announcements about that later, and we'll probably be pumping that through the NMQF streams as well. But just always stay ready with respect to engaging politically. There's an organization around voting that for physicians and empowering physicians to become really very understanding about how, as Dr. Puckrein mentioned earlier, voting and advocacy are branches of medicine. I would also argue that, right? But and that is not a cut on what you all have done in terms of your own training. It really is what's needed for the moment. So I want to pivot a little and talk about, to that point, how then, for those who are interested specifically in helping the administration, how can these leaders on the phone, whether they're trained medically, whether they themselves are advocates or lobbyists, or fall in other categories that matter with respect to getting these ideas out, how can we help the administration understand that equity, and specifically health equity, is a strategy? It's not just a moral imperative. It really is a strategy to help reduce and pull back those inequities, those differences, those disparities in health in terms of treatments, in terms of therapies to chronic conditions like diabetes, but then also the immediate threat of COVID-19. How do we explain health equity? How do we get that message across so that it's enduring?
You know, one of the programs, it was Garrett and Brandon Webb actually brought this program to me, is our 40 under 40 program, which Mia, you are one of our 40 under 40, and so is Ben Gupta and Latrice and Landry and Latasha Lee. We have some incredibly bright people out there who are doing incredible work. They are publishing and they're thinking about the challenges that not just face the minority community, but face the American community more broadly. I'm excited by this whole generation of leaders that are coming up and the leadership that they're going to bring to the table. I have no fear of that. I think we have really just super talented. What we can do, and certainly what we try to do at the National Minority Equality Forum, is provide a forum so they get to know each other and support each other, to encourage their careers wherever we can, to make the introductions. I think they speak for themselves once they hit the door. And I think most importantly for the Biden administration, I would say to listen. I would say that, you know, I'm here in Washington, and I've been going to policy meetings now for almost 20 years. They're not diverse. You know, I had to walk up to one of our industry partners one day. I'm sitting there, and I said, "Come on," you know. I mean, like, come on, right? You got to make the damn thing diverse. right? There are other voices that have to be heard, because those are your clients. The people who are going to use your medicines are in those communities, and you need to understand what they feel and think about. And so I think that's happening. If you look over at bio, the head of bio is African American. Look at PCQA. I mean, so I think the world is changing, and I'm excited about that. I just think what we need to do most with the Biden administration is not try to kill them with demands, because we're all pent up and frustrated. But we need to give them the opportunity, and I think they'll take it, to make sure that my phone is going off, to make sure that these voices get heard, because they're out there. They're really just tremendous. I mean, look at Mia. Mia's fabulous, right? And she's going to be a leader in American healthcare. I mean, she's already leading, and she's going to lead in American healthcare. So I'm
going to take good care of your mantle, Dr. Puckrein. That's
yeah,
what
I hope so.
You've invested so much in all of us. That's what we're called to do.
Yeah,
you know,
right.
Absolutely.
And one thing, just adding to what Dr. Puckrein said, is that for us, I think we just need to make sure that folks apply. I think what happens is you see this, you say, oh, I can never be Deputy Assistant Secretary of this, or Undersecretary of Health, or Surgeon General even, right? But when you come to our summit, you meet all those people, and you realize that, it demystifies the position. So like, we email us, tell us what you want to do. We will send the resumes forward, and they will look at it. They were considering it. Like I said, the good place we're in right now is that we've worked with a lot of people that they have placed up there. The Surgeon General, actually the last 3 or 4 Surgeon Generals we've all worked with. Dr. Cameron Matthews, who's a 40 under 40, who's a Chief Medical Officer at Veterans Affairs. I mean, we have the people there, and we know, and we've sort of vetted them for you, for the administration. So when you send them there, they know that they're quality people. So please, if you have any interest in making changes to the healthcare system, making it better, making it more fair, making it more equitable, please send us your resume at NMQF resume, no S, at nmqf.org. And we will make sure we get it out to the transition team.
Dr. Puckrein, Brandon, Garrett, thank you so much. This has been fantastic. We are at the hour. I want to just, again, on behalf of the audience, and for those who are going to continue to tune in, thank you for your time. And to the audience, on behalf of NMQF, and then also myself with the American Medical Association Center for Health Equity, thank you so much for consistently following. Tell your folk, come back, hit us with more questions. But for the time being, please take care of yourself and your loved ones, and we'll see you again next time.
Yes.
All right.
Thanks
Bye-bye. So much.